So thank you, everybody, for joining us here in the room and online for our first presentation on our first functional forum on Parkinson's. So it's a condition that we've treated kind of in the background, haven't really talked about since the beginning, but we decided finally we should have a conversation about it with the community. So that's what we're going to talk about today is an overview. We're not going to spend a lot of time talking about Parkinson's itself. I'm going to present kind of a novel approach to it, just kind of new in the literature of what might be part of the mechanism of Parkinson's. And then I'm going to talk about some of the treatment modalities, and I'll show you some of the research that the research outcomes seem to support this idea that Parkinson's is at least partially driven by what's happening in the gut. So here we go. First, a little bit about us. So this is a bit of our pedigree. So it's always good to know when you're working with somebody, who have they worked with? So these are our folks, and we owe a lot to them. So this is the main question that we get all the time is there research? The answer is yes. There is plenty of research. You're going to look at some of the top research here tonight. I'm going to show you a little excerpt from a study. This group in Australia and in New Zealand that are doing some groundbreaking research in Parkinson's. So we can see here, we're almost at 4 million studies on electrical stimulation. So that's a pretty solid foundation for us to stand on. Here, if we can break it down into some of the subsets, these are the types of things that we typically treat in the clinic. You can see the evidence base there. Everything we talk about tonight is going to have a grounding in evidence basis. So if you're here for Parkinson's, and we're going to, again, just dip our toe into some of this research. So our focus is kind of broadly bioelectric medicine. And then within that, we do tend to spend most of our time in neuroimaging, neurofeedback, neurostimulation, at-home neuromodulation. But when it comes to Parkinson's, we do bring in some of the modalities that broaden the scope of bioelectric medicine because we get into more photobiomodulation and not just treating the brain. So it takes us outside of a brain-centric approach. And so the umbrella of bioelectric medicine fits more with Parkinson's than it does in some of the other conditions that we typically treat. So of course, in anything that we do, we take an integrative approach. On the dementia side, there would be Bredesen protocol, and Dr. Bredesen setting up a holistic approach. His whole idea of the 36 holes in the roof. And in many ways, Parkinson's is not that different from dementia in that it's a neurodegenerative condition. In both, there's a sense that there is a common origin. And again, it's really difficult to say origin because of the prodrome of all neurodegenerative conditions. There are so many factors that contribute to the point at which a person expresses a symptom, and then we give it a diagnostic label. There's probably 20 years of impacts on their system. So we really can't give it a cause. But Dr. Bredesen has really pioneered an integrative approach to dementia. We haven't seen the same thing happen within Parkinson's, but we use that same model in our clinic, taking an integrative approach to treating all neurodegenerative conditions and indeed all of the brain-related conditions that we address. Okay. So what I wanted to do tonight was kind of show an excerpt from that study that I talked about. There's information on the slide about the study. So if you wanted to go and watch, they've done a great job of presenting their data annually. So you can go and watch 5 years of presentation as they build the research over the 5 years. Worth doing, at the very least, going and watching their 5th year, so this year's presentation, where they summarize everything to this point. It's great. So what we're going to see is just a little snippet of a case study and one of their patients, one of the people in their study, response to an initial treatment. So you're going to see a response to one treatment of photobiomodulation, and then you're going to see kind of at 2 years and at 5 years. So you could see the progression from the sustained treatment.
So Margaret really was wanting to come on the trial so that she can walk in the supermarket and not smash her bag against her leg, because she thought people were thinking she had some issues. So that was very nice. You can see she's asymmetric, she's slow, and she's uncoordinated. So she left the trial first treatment, which was just transcranial. And then she walked out and came back 2 hours later and said, "Could you reassess me? I just feel better." So this is after her first treatment. We reassessed her. So there was a change, we think, with her connectome and her brain waves for that to happen, because the microbiome would not have happened. This is her after 2 years of treatment, and, you know, the joyous facial expression, which she didn't have initially. And this is after 5 years of treatment. So this was, the neurologist was so impressed. He said, we have to extend this to 7 years. Same bag, same weight, same everything. Thanks. And also she regained her sense of smell at 8 weeks, and it continued to improve until she has a full sense of smell and a beautiful rose garden she can now enjoy.
And the other thing that was, she had such severe constipation and diarrhea that she didn't think she could be on the trial, because she would have to stop every 15 minutes to go to the bathroom. She went on to the trial despite that. At 4 weeks, her issues of constipation and diarrhea that had been with her for over 5 years resolved, and she's still in remission from those IBS symptoms. So no gut issues anymore.
So I think it's helpful to kind of get a picture of the whole, like what's possible, see those changes, and then we're going to talk through how did those changes come about, what were the modalities that they're using, what are the modalities that we're using. And I do think it's also valuable at the piece they ended in at the end, that we think of Parkinson's, we think of tremor, we might think of gait changes, we might think of the facial mask, but we don't often think about the GI issues. And so for my clients, often it's the GI issues or the incontinence issues that are the happiest to see the change. Like they might say, I don't care that my tremors go away, but that I don't have to worry about incontinence, or I don't have to worry about diarrhea. Like that can be the biggest change for somebody. So for me, it's been learning that what we see in Parkinson's isn't always the most important aspect of it, and the thing that people looking for help are looking to have change. So here we're just doing a close-up of what's happening in the microbiome. So this is in the gut. The general idea being that alpha-synuclein protein in the gut is misfolded. That misfolded protein makes its way into the brain, where it starts to cause neural inflammation and a whole cascade of kind of a toxic reaction within the brain. And for a long time, it was thought that somehow that was happening through the circulatory system and getting across the blood-brain barrier. So there was a lot of debate about it. Some really good research done, animal model, where they're able to show that was actually coming up through the vagus nerve. So here we have an image of the vagus nerve. So that misfolded protein was finding its way in the brain through the vagus nerve. And so now we have an understanding of how is this bypassing the blood-brain barrier? And it's because it, in part, is traveling through the vagus nerve. So we see that one of the things that we can do is to treat the vagus nerve in a number of ways. One is with photobiomodulation to try and mitigate this passage of the irritant into the brain. So here again, so what do we see of what's happening in the microbiome? That the microbiome becomes imbalanced. There are too many kind of unhelpful bacteria that are producing microtoxins. So that's going to be in our gut. That's going to be maybe causing things like constipation, diarrhea, IBS. There can be just GI symptoms that have nothing to do with Parkinson's, but those can migrate through the vagus nerve systemically into the brain. And then those same microbes in the brain can be causing those same problems in the brain. So we can have neural inflammation because of microbes in the gut. So it isn't just a matter of the misfolded protein. It can also be the unhelpful bacteria in the gut that are causing inflammation in the gut, inflammation in the brain, and can kind of add to this cascade of symptoms that unfolds over up to decades. So the simple photobiomodulation can help restore the microbiome balance. And so here we see an example of like what happens when we're doing GI-based photobiomodulation. We can see changes across multiple sets of symptoms. So it can be motor symptoms, it can be cognition, digestion, all of those can improve from photobiomodulation on the gut. But also what we see in the research is if a person starts to take an antibiotic to eliminate the unwanted bacteria in the gut, we actually see a complete fall off in the benefits. So it tells a little cautionary tale about an antibiotic approach to regulating the microbiome and using photobiomodulation as a natural way to rebalance and not have to kind of kill everything off and rebuild it. But we can just create a supportive environment that is pro-healthy and kind of anti-negative, and do that in a way that is just overall vitalizing. So as we move into some of the broader impacts of what happens once this process is catalyzed in the brain, so how much of what's happening with Parkinson's is environmental factors, so environmental toxins that we encounter over our life, concussion, brain injury that's doing direct damage to the brain, the food that we eat and the toxins that we ingest there, even if it isn't toxins, if it's just not healthy foods that we're eating, all of these things are kind of putting a little dent in our resilience and our immune system's ability to care for the body. So they add up. But there are some of these bigger players when we look at the misfolded proteins that we see drive processes that if our body isn't healthy, it can't stop. So we've talked about, I mentioned photobiomodulation. So one of the main things that's happening, so this is using red and near infrared light. Anywhere on the body, you get the same 35 benefits wherever you put it. One of the ones that gets the most attention is driving the activity of mitochondria, and that would be ATP or energy production. Typically is what we think about it, but now we know that mitochondria spend a lot of their time and maybe more of their time doing cell-to-cell signaling. So they're doing what we typically think of neurons doing in the brain in terms of they're communicating information. It turns out our mitochondria are doing that as well. So if our mitochondria are impacted, it isn't just lowering the available energy to drive our physiology. It's also taking out an entire communication system that is helping our body prepare for what it needs to do in advance of whatever's happening. So kind of a pre-communication. So, but along with that, again, we have these 34 other benefits, things like reducing inflammation and balancing reactive oxygen species and increasing nitric oxide production, neurogenesis, synaptogenesis, vasogenesis. So we have a lot of positive effects coming from photobiomodulation. And that starts to explain why do we see so much happening? Why is there so many benefits that come from this relatively simple intervention? Just put light on the body and you see those changes for that lady in one treatment. So here, looking at the cycle again of what happens when the irritated gut and how it has a systemic effect. We're looking at from a treatment standpoint, we can put light on the GI tract. That makes perfect sense. Maybe less intuitive is to put light on the vagus nerve, as it is kind of most available right up here, kind of around the C1, C2 vertebra. And so again, that's a chance to kind of pre-treat what is moving into the brain. And when we treat with photobiomodulation, we also affect blood, and irradiating the blood is also going to mean we get irradiated blood going into the brain, and it also has a whole cascade of positive effects. So here, another way to get light into the brain. So this is using intranasal irradiation or a nasal laser, which is exactly what it sounds like. It's 1 or 2 lasers that you put in your nose to shine light up into the brain. So this allows us to get brain into the underside. So a loss of sense of smell is not uncommon in Parkinson's. So the olfactory bulb, you can see there where in that image, the blue arrows. So that's the olfactory bulb, the source of smell in the brain. So we're going to be irradiating, stimulating the olfactory bulb as that light passes through and gets to the underside of the brain. So it's a novel approach. It seems kind of weird. It's the one that I get most clients kind of look at me sideways and think, really? I'm going to stick laser up my nose? But it is a benign intervention. You're going to get to see a picture of it in a little bit. And as funny as it looks, the main thing is it's effective and people get positive change from it. So then additionally, we're going to do some transcranial alternating current stimulation. We're going to, again, see that in play here in a little bit, but Fran is going to talk about it in more detail. So that helps us work on how the brain is talking to itself. So working on the functional patterns of communication in the brain, that the process of Parkinson's can begin to interfere with how the brain communicates with itself electrically. And since that's the language of the brain starts to get out of sync with itself. So we're using transcranial stimulation to help resynchronize the brain. Auditory stimulation. So we're going to see a couple examples of rhythmic auditory stimulation. That's often done as music therapy, which I think is great. But We're also going to see an example of audiovisual entrainment. And the audio entrainment, we usually think of binaural beats having a certain function in the brain. But here, that beat has another function in Parkinson's, which is to help the brain kind of correct its timing mechanism. And again, I'll show you a few videos where you can just see how immediate that effect is. And then again, Fran is going to talk more about EEG and neurofeedback in a little bit. So then sleep, of course, so important for all of us, but we find in the neurodegenerative conditions, sleep loss kind of comes along with the degenerative process. So it can be part of a negative cycle as we don't get enough sleep. Our brain can enter into the glymphatic cycle at night, so we can't clear toxins. So that toxic load builds up. It causes more dysregulation in the brain. That drives more sleep loss, and you can just see that cycle repeating. So sometimes one of the most important things we can do for our clients is just help them get a good night's sleep. And in that process, there's just all the regeneration that happens with sleep, but there's the turning on the glymphatic system. So the lymphatic system of the brain, glymphatic system, to help clear out those toxins. So incredibly important, the whole cascade of sleep. And the primary thing that we use for that is the audiovisual entrainment. And then what we see is as we combine the transcranial photobiomodulation, the audiovisual entrainment, so the photic entrainment in the eyes, the binaural beats in the ears, and the nasal laser. So all of those modalities combined into a singular treatment, typically done at home, 30 minutes twice a day is a typical treatment protocol. We can see that we can get a cascade of change in the Parkinson's symptoms. So we can get tremor reduction. Audiovisual entrainment is, I've found, to be one of the best ways to address tremor in Parkinson's. Often can take somebody from, like in one of my cases, a gentleman who was severely tremoring about 8 hours a day. He was almost completely bedridden. About 3 weeks of audiovisual entrainment, so daily audiovisual entrainment, his tremors were down to negligible. He then backed off doing the audiovisual entrainment for a week. Tremors started to come back. He went back into audiovisual entrainment. Tremors went away. And what this did for him was allowed him to get up in the morning, get dressed, navigate the house. He started to be able to cook for himself again and just do general household activities. So that was a fantastic gain for him. But the other side of that was his wife, who was his primary caregiver. She had to be attending to him all of his waking hours. So that meant she didn't get to leave the house very often. When he regained his independence, she regained her independence. She was able to get out and start going and visiting friends again, start playing cards with friends again, and get back her social circle and her social support. So we can see that these changes aren't always just for the person with Parkinson's. Okay, so we're going to take a look at a video for the rhythmic acoustic therapy.
Empirically illustrate balls relate to the timing of a musical beat.
What's happening right there is they just turned on the music, which is earbuds for her. See that line came on across her feet, the light line on her walker. That's indicating that the music is playing. So two great examples of just seeing how that acoustic therapy can just immediately change gait. And that's by giving the motor strip and organizing rhythm. So that's part of what's happening in Parkinson's is a disorganization in the communication within the motor strip that results in the various symptoms that we see. If we can help that motor strip have an orientation so the beat of music is enough for it to grab a hold of, to help reorganize itself, and we see changes whole body. You could see in the first one, the arm movements changed. In that first video that I played, one of the first things maybe you noticed was at first her arms were not swinging at all. And in that, after one treatment, she could walk with arms swinging. So seeing this kind of really kind of profound change, just in a single administration of the technique really brings hope for what's possible. So for us, we take an integrated approach, as I've talked about, and I think this next image kind of shows you the integrated approach. So rather than just talking about it, I'll just show you. So here she has on a near-infrared helmet. So that's near-infrared light, transcranial stimulation for all of those 35 benefits that come for helping the brain vitalize and heal. So that's really what we're doing, is we're just vitalizing the organ. We're not treating a disease. And so this is an example. So it was a different helmet used in that initial video that I showed you, but it was this type of a device that after a single treatment changed her gait so dramatically. And then layered in here, you can see the nasal laser. So her nose is kind of glowing like Rudolph. So that's the nasal laser. And then the glasses are part of the audiovisual entrainment. So that's photic entrainment, light in the eyes. You can kind of see a little red glow through her hair. That's ear lasers. So we're doing lasers in the ear. That just as well could be swapped out for the binaural beats. We'd have earbuds, but instead of light, they'd have sound. So we can do the binaural beats and then the transcranial stimulation through ear clips. So we have all of those modalities being delivered at one time. Again, a typical treatment protocol, 30 minutes twice a day. It does need to be continued across time. If a person backs off, their symptoms will start to reemerge. And so we really look at this as a lifestyle type approach, just like a diet and exercise lifestyle approach, same thing here. So this is a couple that I've worked with for about 4 years. So when they came to me, her Parkinson's symptoms were definitely present, but she was fairly early in her diagnosis. But they realized that her symptoms had been creeping up for a number of years, but they really didn't put it together. But her symptoms were, I would say, like moderate. And then you'll get to hear her story of how that's gone over the 4 years of treatment.
Thank you, Doreen and Murray, for making time to talk with me today and share with other people interested in devices. If you just share a little bit of your story and how it's gone.
Well, it has been very good. When I was first diagnosed, I thought like, wow, is this the end? And then we were introduced in treatment of anything. I didn't really notice too much, except that I thought maybe some of the anxiety was gone. And I think that was directly from the light, because there was nothing else that gave me any kind of hope. And I joined a group with the Alberta Parkinson's Association, and there was a couple there that had been diagnosed about the same time as me. And when I told them what I was doing and they wanted to know what the cost of it was, they just said, oh, well, that's, can't afford it or whatever, but they have not done it. And I just feel that I haven't regressed like the rest of them have. So, and then, we worked with the light, and then I had there isn't much, but he said, you really haven't, your Parkinson's has not progressed. He said, I think you're staying where you are, but he doesn't know why. Of course not. And when I told my family doctor what I was doing, he said, oh, good, carry on. And that was all I got there. So anyway, so then been using the helmet, and usually twice a day. I don't have that now since I got the new helmet. I don't have that.
Great.
And I don't know what it is, but the only thing that's different is the red light. So it has.
Sure.
Yeah.
That's wonderful. Murray, what have you seen in Doreen over the years?
Well, I've noticed that she says that she hasn't gone downhill at all. That's occurring, which is wonderful. The thing I noticed the most is a month or so ago when we were off, and now starting back up again, I see a freshness. There's a bit missing.
By willing to be on camera and tell your story and know you in this way. So thank you for doing that.
You're very welcome.
Thanks for your
Thanks
help.
for all your information.
Okay.
Yeah.
So a delightful couple that I've had the opportunity to work with for a number of years, and I've worked with a number of people in their community, and they have seen similar results. So I love the opportunity to work in these areas where there is a sense of no hope, and how this can bring hope for so many people, and in many ways, and so simply. Paul, you had some questions.
One, I used to tremble, and I got rid of my trembling by having a stroke. And I didn't have a stroke. And the other thing is that you mentioned all these things that, I don't know, it's semantic, but you mentioned that this does something in your stomach. Is there any way to detecting it before it gets, maybe a determination of that. I like the argument of what happened, you don't change.
So let's see if so the question is, when I was talking about the GI, and it's starting in the GI, and is there a way for them to detect that earlier? Is that the question? Yep. So I would say probably the earliest detection we have is doing genetic testing to see if there are the genes that predispose somebody. Well, there's genetic markers for, so it's challenging to say exactly what those genetic mutations are leading to. The general suspicion is they're driving the mutation in the protein folding, that's, yeah. So, but the main thing from a genetic standpoint is the genetics only make a person about 20% more likely to have the condition. So I think it's worth doing. And we use a company that does a genetic test, and there's a lot of why we use them versus anybody else. But genetic testing now is so available. I think doing the genetic test is worth having the information to just know I have an increased risk. But it isn't predictive. Its strength of prediction is limited. So in a way, the answer is no. We don't have a good test yet that tells us early enough that one is going to have it. But the reason for that is Parkinson's doesn't have a cause, right? So a person could have the microbiome issues that could lead, but they may never develop the disease.
If you could happen, change your lifestyle, decreases chances of greater.
Correct. So now probably the diagnostic thing that people might get is something like a leaky gut. So you might see a functional medicine doctor or a naturopath and get a diagnosis of leaky gut. So what we were talking about earlier, where the microbiome is moving in a direction that's kind of unhelpful. So too many unhelpful bacteria, or the wrong bacteria in the wrong place of the gut, but it leads to a cascade of things, inflammation being one of them, that can thin the lining, and then those bacteria can get across the gut lining into the body, and then that starts kind of an immune response. And so that, in a sense, that's leaky gut, is unhealthy microbiome that breaks down the function of the gut and then produces symptoms. So that...
Why would they, there sounds like they should have different, I don't know, the examination when you're younger to see if there's some kind of a mystery, right? Because if somebody special, they'd recognize it at least a better chance than not a better chance.
Yep.
Mine has got a lot of that stuff.
Sure.
And he felt this when I was younger.
Yep.
But sense of sound, taste, I don't have that.
Never got that back? Okay. Well, there's something for us to work on. So we could work on that. But I agree. I mean, I think as we're linking these things backwards, now a person can have the idea that if you're seeing an adolescent that's having GI issues, something that might be leading towards an IBS, so an irritable bowel syndrome, that we can know that this going untreated, this person has a higher likelihood of ending in a neurodegenerative condition. Now, maybe it's too early at age 8 to say which one, but we could see that they're on a trajectory that is headed in an unwanted direction. But we already see now that is being paid attention to and being treated in a way that isn't pharmacological, that really drives a further breakdown of the gut, leading to an ongoing lifelong battle. So the research is feeding back, and I think we're building a better model, but it is true that we don't have a good predictor yet.
Actually, would that be symptom?
That is classic of inflammation in the intestine. Yep, absolutely. Yep.
We've been talking about some of the symptoms that show up with Parkinson's and the areas that I've spent some time talking about the brain. We wanted to spend a little bit of time talking about this idea of, like, while there's a lot that is talked about in regards to dopamine in the brain and how that gets impacted with Parkinson's. But it also, autonomic dysfunction is also very widespread when it comes to Parkinson's, and there are some ways that we can look at kind of identifying and treating the autonomic system that can be really helpful in either mitigating symptoms of Parkinson's or sometimes slowing down the progression of the disease. What the research talks about is the idea that when the autonomic nervous system is failing, so that's the kind of the sympathetic and the parasympathetic. So the sympathetic is kind of the fight flight part of the nervous system, the activation part. It's not all negative. And then the parasympathetic is kind of the calming, the rest digest. So when that starts to fail in terms of it kind of being balanced well in kind of playing both sides evenly or responding well, it can act as like a kind of prodromal biomarker for Parkinson's. And so that's a thing that can really start to show up. This is what you were asking the question about, you know, things that might show up. This is something that can show up quite early, and we can assess for it to see whether or not the autonomic nervous system is functioning optimally or having some type of dysautonomia occurring. And then we can work on treating so that the individual is balancing better, and it has a positive impact on both the progression as well as kind of slowing some things down. I'm sorry, what? Not being said, we're looking more at like kind of the physiological, like the autonomics. And so we'll spend a little bit of time talking. I'll talk about it in a second. So we'll get it. Yep. So when we look at the impact of autonomic dysregulation, so think about your nervous system, right? And the autonomic nervous system, it's a physiological process, right? And so it's not about the emotional component. So depression is, as you're talking about, is more of an emotional kind of thing. We're really looking physiologically at things. So what happens oftentimes is that somewhere like outside of the brain, so in the peripheral nervous system, right, some dysregulation can start to happen. So Guy had talked about the gut biome, the gastrointestinal piece of this, and how like nerve fibers can start to send messages that can start to negatively impact the autonomics. We also see that with cardiovascular system, hypotension, which ultimately we're going to see kind of shows up as can be low blood pressure, but also just like people experiencing lightheadedness, syncope, those brain fog sometimes can be a part of that. These things can, as you can see here, the research is showing that some of these symptoms show up between 5 and 20 years prior to any of kind of what we think of as the more typical symptoms of Parkinson's. So the tremors, the slowing down, the rigidity of movement, that kind of thing. So if we can identify and work on these areas early on, it can have a pretty significant impact on overall well-being. With cardiovascular failure, what that actually looks like in terms of autonomics is several different things that if you look, there's some research that has kind of referred to this as like the triple whammy that can happen. So there's some sympathetic issues that start to happen. So basically the heart can lose its like the sympathetic wiring. So the kind of the activation piece of the sympathetic wiring has to do with norepinephrine being the production and processing of norepinephrine being disrupted in some way. Can also have some failure in like some constricting of blood vessels. Can also kind of the baroreflex, which is kind of the brain's internal pressure monitor, can start to fail to signal. All of those things, kind of the clinical result of that can be lightheadedness, the syncope, the brain fog that's caused by like a reduced blood flow to the brain. And so we can identify those things early on and do some work on regulating those autonomics so that they don't lead to a more significant impact. Okay, so heart rate variability is kind of the thing that we do a lot of talking about in our clinic, and we do a lot of work in both assessing heart rate variability and then training it. So heart rate variability is really kind of measuring like the beat to beat variations in your heartbeats, right? And all kinds of research in the area of heart rate variability that really starts to indicate to us that if you have lower heart rate variability, it is correlated with a higher risk for disease progression. So we're talking about Parkinson's tonight, but it isn't just Parkinson's. It can be cognitive decline, cardiac kinds of issues that the progression of them is more likely higher. The risk of the progression is higher when heart rate variability is low. No, we're not talking about heart murmur here. We are talking about like when we look at heart rate variability, we're looking at how, like, when a heart beats, right, from the space in between this beat and the next beat, and then the next beat and the next beat, should be variable. It should not be working like a metronome, right? And so that's something that we do in the clinic on a regular basis with clients, is we assess heart rate variability. Because if it's metronome-like, you're going to have low heart rate variability, and that is correlated with increased risk of disease progression as well as like all-cause mortality, that sort of thing. So there are some measures for heart rate variability. The couple that are on the slide up here they're kind of primary ones that are oftentimes looked at. And really what they're looking at is, so the SDNN is really looking, it's the average, like the average spread of all of your heartbeats. So it's a mathematical process that they do that is done that kind of gives you a number that is indicating kind of what the average is of your heartbeats, right, during the day, right? So the stressors of a day and then over time. If it's low, it means that the heart's kind of getting stuck beating too much like the metronome, right? So it's not a lot of variability in there. And then if we look at the RMSDD, it really is kind of looking at the change from each single heartbeat instead of looking at the average, right? And so what it can really show us is like how well your parasympathetic nervous system is working. So the parasympathetic is the part that's going to kind of kick in to do the rest and digest, right? And the calming part of the autonomic nervous system. And this particular index, again, it's a mathematical index that can be computed, but it really shows how well that autonomic nervous system is working. So for people with Parkinson's, the idea here is low HRV, including these indices that are part of that, leads to more risk of the disease progressing quick. Any disease, yeah, absolutely, yeah. And then Guy talked about this. There's some good research that has looked at how the slowing of gastric emptying, so that's part of the gastric issues that can happen, right? That can alter the way oral medication is processed. And so medications that you might take to deal with the tremors, to deal with movement issues with Parkinson's, they oftentimes can't reliably reach the small intestine, and so they don't get absorbed well if there are these gastric issues going on. Again, working with the autonomic nervous system, working to regulate and optimize heart rate variability can improve those gastrointestinal issues as well. Yeah, it's not the medication, it's a heart rate variability. You can manage it. Like if you're talking about, are you talking about the heart rate variability, the space in between beats that I was talking about? That the autonomic, like if you do heart rate variability training, right, and you teach your body how to do that, and we'll talk about that in a second, you can work on enhancing and optimizing that. Yeah. So from a clinical perspective, in our clinic, we are oftentimes looking at integrative approaches. That's what we do all of the time. And so for dealing with the autonomic disruption that can happen and can be both a part of Parkinson's, but also kind of a precursor. We pull in a variety of things, the HRV or heart rate variability, breathing, it's biofeedback that we're doing. Guy talked about the vagus nerve, and so we can help clients work on vagal toning through using photobiomodulation, and there are simple exercises that individuals can do as well to help tone vagally, but PBM would be best in this circumstance. You can, for autonomic regulation, maybe pull in some somatic processing kinds of interventions as well, so that we're really setting the system up, the autonomic system, to be as supportive as possible as it can for somebody who is in the midst of dealing with Parkinson's and the symptoms that come along with that and the progression. Sure. Yep. So with heart rate, with that heart rate variability, we're looking at a certain number of breaths per minute in which your autonomic nervous system works the best. So it's about how many breaths per minute you are breathing, right? And that determines how, and that does vary, but it's typically between 4.5 and 7 breaths per minute. And it's not about it varies from individual to individual. And so the fact that, you're German and I'm Czech, that doesn't necessarily mean that you'll have it different because you're German than mine, right? Sometimes there's body size matters. There are some other factors that make a difference. But again, we can assess that through an autonomic nervous system assessment that can give us the specific information about where you should be breathing, how many breaths per minute, where I should be breathing, where somebody else should be breathing. Yep. But I would tell you, even though it would have been beneficial for you to have it a long time ago, it's not too late, right? Yep. So when we do assessing in the clinic, we wire you up so that we can monitor some physiological metrics. And we are able to, we have software that identifies those breaths per minute. It's referred to as a resonant frequency. And then you can train yourself we can work with you to train to start breathing at that rate, to kind of make that more of sort of like your baseline rate. Now, we don't want you to never, have your sympathetic nervous system kick in, because you need to do that sometimes. But for your baseline to be what your resonant frequency is, will optimize your system in a way that will help to reduce the risk of a faster disease progression. With what? Yeah, it's managing your nervous system, right? So it's going to calm you. You're going to function better in that way. It's not really directly correlated to managing balance and that kind of thing. But if there is emotional, if there's anxiety kind of around some of that, it will help with that, which can help then to some extent, but it's not a direct management of that. Yeah, sure. Yep. Then I'm going to move on and talk about a couple of other things. One of the things when you start looking into the really current research on Parkinson's, and if you look at it specifically having to do with neuromodulation, neurofeedback, that kind of thing, a lot of the research is talking about, rather than referring to it as a movement disorder, referring to it as an oscillatory circuit disorder. So oscillations are just brain waves. That's what they're talking about, is that some of what can happen is that brain waves can get what we call hypersynchronized. And when they get hypersynchronized, they kind of get stuck in a loop, right? And in particular, what they notice is beta waves getting hypersynchronized. And oftentimes that's over the motor areas of the brain. And so when they get stuck like that, they become rigid, and that can contribute to the rigidity that we see. And so there is a lot of research looking at that beta hypersynchronization, and then looking at ways that we can work on desynchronizing it. So that it's kind of like, if you would imagine I don't know, a room full of people just standing here still and just all kind of crowded together. And then imagine a flash mob just coming in and kind of disrupting the room, right? That's what we can do with like transcranial alternating stimulation, is we can have the kind of stuck or hypersynchronized beta bands be desynchronized by just disrupting them with another frequency. Medication works on the chemicals. Brain waves are really kind of what are responsible for the chemicals. Chemicals are just kind of messengers, electrical messengers, right? And so neurons will send an electrical message from one neuron to the next, to the next, to the next. And that's what medication is doing, is working on that. That's what, well, it would be the same thing, right? Is that, and dopamine as a chemical neurotransmitter, I mean, does a lot of different things, right? Yep. Yes. Yeah. And so but the brain waves are kind of what ultimately kind of allows or disrupts the proper movement of those electrical signals or those chemical signals that are happening. Yeah. So one of the things, I'm going to move through this a little bit. So one of the things that we look at is the kind of the motor areas of the brain and how those are impacted by that hypersynchronizing that happens. And when the, like, if things get hypersynchronized, think of it as kind of getting clogged, right? And then the functions that are supposed to be happening within those areas don't happen as well. And so that can sometimes have an impact on like dopamine and a loss of dopamine that we oftentimes see with Parkinson's. Yep. There's also some good research looking at the central executive network. And so what's really interesting is your supplemental motor area in your brain it sits kind of right at the intersection of the motor network or the sensory motor network and the central executive network. And so the central executive network is in the frontal part of your brain. Think about executive functions like planning, organizing, decision-making, all of those kinds of things, but also emotion regulation. Well, the supplemental motor area, which is indicated as being pretty dysregulated oftentimes with Parkinson's, is kind of sitting right at the intersection of the sensory motor network and this executive function or central executive network. And that when that gets disrupted, it can have a pretty significant impact on that. And so one of the things that we can do with neuromodulation or with neurofeedback is to work on targeting that node, where that intersection is, to influence both motor execution, but also the cognitive functioning that comes with the central executive network. And that can have a pretty significant impact on regulating some of the what we see dysregulated with Parkinson's disease. Is which kind of therapy? I didn't. Yeah. Well, yeah. The piece that's not like the regulation at the brain level, right? That's not a physical therapy process, right? That is more of a neurotherapy process. Yeah. So the neurotherapy is the other piece of that component. And what I would say about that too is that the neurotherapy can optimize the brain in a way that can then optimize the physical therapy, because the physical therapy is. So when we look at doing transcranial alternating current, there's a couple of things that we look at. I'm going to just skip through a couple of these. I want to move here and then I'm going to go back to the other slides. What the research is showing is with that kind of hypersynchronized beta that happens right across the motor cortex, it's kind of like that metronome of beta happening. It needs to sort of be loosened up. Right? We need a flash mob to come in here. So this slide is showing us how that happens. When we use transcranial alternating stimulation and we stimulate those areas with gamma wave rather than beta wave, what that tends to do is seems to smooth things out. So there's a lot of good research on this. So it's basically stimulating the brain or entraining it to start producing the gamma, which then disrupts the beta, the kind of hypersynchronized beta. And so what we end up seeing, and you can see it on this slide here, is that there is like we see over on the left side, the kind of synchronized, kind of hypersynchronized beta happening. And then we do an intervention by putting some gamma on the brain, stimulating the brain with it. And if you see over here, then this image on the right side is showing how post-treatment, the brain is now desynchronized in terms of the beta and has more of that gamma wave showing up. And so we've managed to kind of break up that hypersynchronization. Yeah. I think we're talking about two different processes there. So I've been talking about transcranial alternating current. That's current to the brain, right? That we're stimulating the brain with particular frequencies. We also can work on those networks. So I talked about the central executive network. I talked about the motor networks that are in the brain. Neurofeedback can be used, 19-channel neurofeedback in particular, to do some deep brain guidance, to really start to work on regulating the network. And so once the network is regulated, the functions of that network can happen much more smoothly. If the network is dysregulated, either the functions are impaired to the point of not being able to happen, or they're happening, but they're not happening in a very smooth way. And so by regulating, we can start to optimize the network in a way that allows for those functions to run more smoothly. This is just an example of 19-channel neurofeedback happening, where we are training a brain network to learn to optimize itself, to regulate itself. And so we do this with a video game where this person's brain is getting operantly conditioned to respond or to behave in a more well-regulated way. And so that's an example of what we might see with neurofeedback. And then neurostimulation. So this is I like this particular slide because I think it highlights what I was talking about with kind of breaking up a brainwave process that has been hypersynchronized. This is really dealing with tremors, and it's looking at what the research is showing about tremors is it seems to be more related to the theta wave frequency as opposed to the beta. And so we might put like what is referred to as an anti-phase protocol of transcranial alternating current on the brain located in some motor areas that's really meant to kind of do the opposite thing. So what you can see on the slide here is that there is theta wave happening, right? And then you can see that that's the red wave up top that's gotten kind of pathological and is leading to that tremor behavior. And then the blue wave beneath is kind of like the exact opposite. It's an anti-phase. It's kind of pulling it out of phase. And it is a way to kind of counteract the dysregulated or dysfunctional theta wave that's happening. The goal being to kind of break up that kind of rigid theta wave that has started to happen, and as a result, to it kind of on a behavioral level, it reduces tremor. This video is just showing you an example of what it looks like to have. I'm going to pause this one here. I think there to get transcranial alternating current done. Right? So this person has some sensors on her head that are delivering the alternating electrical current. And then the cap you see with the coils has some electrical magnetic current occurring as well. And then we can also we've got like a photobiomodulation device in there so that they're getting some of that at the same time. But this is what happens. Somebody comes in, we wire them up, and they lay back and relax and have the treatment done. So you can see on the computer screen that it's delivering a particular frequency, right? And so that's what that kind of treatment looks like. And so oftentimes what we'll do in the clinic and what the research talks about in terms of looking at treating Parkinson's and specifically looking at the physical pieces with transcranial stimulation and neurofeedback is to start with the transcranial alternating current as a way of kind of breaking things up a bit, kind of like an icebreaker, and then moving over to the 19-channel neurofeedback to train the network to make it much more, to take kind of the temporary effect that happens with transcranial alternating stimulation and turn it into more lasting permanent changes. When we do neurofeedback, the idea is we regulate a network and really it's kind of creating new neural circuitry, right? But more optimal neural circuit runs. And then the brain's natural neuroplasticity is going to just continue to strengthen after the training is done. So I wanted to spend just a couple of minutes talking about the idea of caregiver burnout, and because there's a lot of research being done on this. And I think one of the things that oftentimes happens is when somebody has something like Parkinson's disease, dementia, something like that, oftentimes there is some extra requirement for caregivers. Guy talked a little bit about this when he was speaking as well. And the reality is that the toll that it can take, like the caregiving can take on the caregiver, not only impacts the caregiver, but then also the person they're giving care to, because they're not able to give the quality of care they might be able to if they weren't experiencing the burnout. So always important when we work with people we talk with caregivers about the idea of them taking care of themselves as well. There's a lot of current research being done on the impact of kind of chronic caregiving, the stress of that. And they talk a lot about how that kind of wear and tear on the brain can lead to a state of allostatic load, just where the body's systems are kind of constantly on. And so we think about like the sympathetic nervous system just being stuck on, right? And that can get pretty fatiguing to the brain, to the physical system, and emotionally fatiguing then as well. And so lots of impact that we see for caregivers in this regard. And so it becomes crucial for them to be taking care of themselves as well. And so what we oftentimes will do is, I'm going to grab this here, is we'll create this kind of a treatment package for caregivers as well. And it's, I know that when I talk with clients who are taking care, are kind of in a caregiver role, my advocacy always is whatever we're going to do for the person that's, got the illness or the disease happening, we need to make sure that we're addressing you as well so that you can do the things you want to do to be helpful for the person who you're taking care of. And so there are some really helpful therapeutic strategies. Photobiomodulation, Guy talked a lot about that. All of those 35 benefits that it gives to people who have Parkinson's or other kinds of illnesses, it also will give to the caregiver who is wearing the helmet, right? And so that can be a really helpful intervention. Neurostimulation can be good. We have in our clinic, we call it our brain spa, where people can come in and just get some neurostimulation. So with neurofeedback, you typically are doing kind of a treatment regimen of about 40 sessions. With neurostimulation, because it's more of a treatment paradigm, we have that available for people to come in and they can get neurostimulation to help them manage stress, maybe a parasympathetic protocol to help them manage some of their own stress around it. And then Guy talked about the audio-visual entrainment. That is a device that is just, I can't ever talk highly enough about it in terms of its ability to help people manage stress. It entrains the brain into particular kind of states. And so protocols for calming, protocols for sleep, protocols for focus, all of those things that start to get compromised when somebody is in a caregiving role that has become more chronic or long-term for them. And then obviously always getting support, right? So whether that's you're working with a therapist, you're working on, you've got a support group that you're working with. There are local support groups in the Twin Cities area. There are also, I've got on this slide, a couple of support groups that are more national, so they have online support groups available. Very critical. Caregivers are oftentimes so busy taking care of that they forget about the very important piece of taking care of themselves so that they can do the caregiving that they want to do. Okay. So that is what we wanted to share with you. If you're interested in getting more information, if you're interested in a consult with us, there is information up on the screen here. You can scan the code on your left. If you're interested in a consult, if you're interested in if you're a caregiver who wants a little TLC, the QR code on the right gets you right to our brain spa package. You can get a package, a membership. You can purchase a session that way. And then we always include, we've got an affiliate program that we run through the clinic for people who may be interested. Maybe they're working in a field where they have a lot of customers or clients that they're working with that they think might benefit from the services we have. We have an affiliate program, so you can partner with us to do those referrals. Yeah, I think you're right about that. I think we believe that there is not enough considering of the brain in terms of imaging, right? In our clinic, we do quantitative EEG, so brain mapping, where we look at the brain. We record brainwave activity. We do a really thorough analysis of the brainwave activity so that we can identify where there's dysregulation in the brain. And then that can inform us about all kinds of things, about treatment we might want to do, recommendations we want. Yeah. Yep. Absolutely. Yep. Would agree. Yeah. Okay. Well, thank you all. I appreciate you attending tonight, those of you online and those of you here. We look forward to seeing you next, in July, first Tuesday of the month, we have Tenzin Namdul, who will be here talking about Eastern practices, Tibetan medicine practices for brain health. It's going to be a fascinating conversation. There's information up on our website about it. If you found us through Eventbrite, that it is up on Eventbrite right now. So certainly feel free to sign up for that and get your seat ahead of time, because I think it's going to be a really fascinating conversation we have. Thank you.